I did that. Totally confused by leukemias yet? Good, because it gets worse. Just so you know. Okay. So these are our ALLs. Okay, first of all, did any of you come up with, or did you all come up with what you want to do for studying? Do we want to just try it one more week with what we've been doing? Do you want a more detailed study guide? Any suggest, because like I said, if it's a more detailed study guide, the questions are going to be harder. So I'll let you discuss at break. Let me know later. Okay. I just need to know what we're doing. All right, precursor or acute lymphoblastic neoplasms. If, God forbid, your child has to get leukemia, and I pray it never happens, but if they have to, this is the one you want them to have. It affects children primarily between ages 2 and 10. It is most common in little ones. They have about a 90% remission rate, which means that they can knock it back in about 90%. A cure rate depends on how old the child, once the child gets past a certain age. So the cure rates go up slower only because we gotta wait for the kids to grow up. As the kids who were in these first trials of vincristine and in the earlier, once they started getting the treatment regimes under control, as they get older and older, those cure rates are going to get higher and higher. In fact, I think it's closer to 70% now than 60. Okay. This is my one plug for, I have two plugs that I ever made. One is for organ donation, and the other one is for if you ever have a little bit of money that you just want to help somebody out, St. Jude's Hospital, because this is almost entirely due to them. They charge nothing to their patients. They make no money off of anything. And the nicest thing is they're not a pharmaceutical company that has to make money to reimburse its funds. It's not a university that has to make money off of its cures to fund future research. And they came up with vincristine, and as soon as they came up with how to treat this, they pretty much put it out there and said, this is it. They didn't take any money for it. They didn't keep it. There's a lot of places they'll find a cure, and you come to our place and you can have it. They were, here you go, and just freely gave it out and said, this is what it is, this is how you use it, and gave, I mean, it's still not cheap, I'm not saying that, but they do, when they find something that works, they do share it freely. But that is pretty much where we are, where that comes from. In adults, the prognosis is much poorer. They can usually knock it down once, maybe even twice, but the remission rate is about 70%, which means we can get it to go down for a little while, but it comes back with a vengeance and is usually fatal on the recurrence. It's just not as easy to take care of in an adult. We basically have a decreased cell count in general because, like I said, the production in your bone marrow is very, very busy making all of these lymphoblasts. And so it's not making anything else. Again, fatigue, fever, and bleeding are common symptoms. Organomegaly and bone pain are common. You've got excess marrow production, so your bones are going to hurt. It does have a fairly poor prognosis in children less than 2 years old, although again, that is getting better. If we have an increased lymphoblast count in the marrow, it does have a poorer prognosis, but again, that is getting better. The presence of Philadelphia chromosome, the BCR-ABL, as the young man I was telling you about, his chances went from 90 to 20. Those chances are creeping back up because, since it is genetically the same as CML, that Philadelphia chromosome is the one that we see in chronic myelogenous leukemia, He was one of the ones in a trial group that they thought, well, if it's the same genetic predisposition that we see in chronic myelogenous, and we treat chronic myelogenous with Gleevec, I wonder if we treat the Philadelphia chromosome BCR-ABL positive ALL with Gleevec if it'll work. And bagosh and bagolly it did. When he was in the trial, he was the 20th or 21st patient, but they had a 100% success rate. There were only 20, very small number. But as they have gone more and more to that, it seems to have increased the survival rate in patients with BCR-ABL positive ALL. It is also a poorer prognosis in Native Americans. Why, I don't know, just genetic, the way it works. This is not the word all, this is ALL. ALL, lymphoblastic leukemia, primarily involves the bone marrow and the blood. It is not in the extramedullary tissues. It is almost always B-cell leukemia. About 75% of all of ALL in children is B-cell leukemia. T-cell ALL is more common in adolescence, and it is much harder to deal with. Lymphoblastic lymphoma, and pretty much the difference between a leukemia and a lymphoma is where it arises. If it arises in the bone marrow, we usually refer to it as leukemia. If it arises in the extramedullary tissues, such as the lymph nodes, the thymus, the spleen, or any of your lymphatic tissues, or anywhere in your body, we refer to it more as a lymphoma. What we see with these lymphomas, we have a mass lesion with little blood or bone marrow involvement until severe end stage. Okay? It is mostly T cells, and it's most often present as a thymic mass. The thymus is a gland in the chest. Yes?
I was going to say, so it's not a liquid cancer.
It's not a liquid cancer, right? It is usually a solid tumor. It will evolve eventually and involve the bone marrow. Then it becomes the other. But yeah, this is the tumor. Yes.
What's the acronym for ALL?
Acute lymphocytic leukemia, or acute lymphoblastic leukemia. The morphology is very, very similar. Pretty much you cannot tell the difference between the two just by looking at them. Maybe there's some pathologists out there who've got some eye for it, but for the most part, it's very difficult to tell the difference even between a lymphoblast and a myeloblast, just morphologically, let alone try and tell the difference between the two types of lymphoblasts. So there's morphologically very similar. What we're going to do is we're going to differentiate them using immunophenotyping. Okay? And I have a handout of an algorithm that I'm going to give you. ALL are TDT positive, except for Burkitt's. Okay, L1, L2, L3. The ALL is TDT positive, except for Burkitt's. We'll see that one. That one's pretty self-explanatory when you see it. But we do differentiate them with immunophenotyping. And yes, that might be something I asked on the test. Clinical correlation of genetic abnormalities in B lymphoblastic neoplasm. Boy, isn't that just a fancy schmancy word? Basically, all we're looking at is if these are if we have a genetic abnormality, what's it going to do for us? Our BCR-ABL, most of it's in adult, very few of them in pediatric. Risk, poor prognosis. Risk actually should say probably prognosis. Poor prognosis. Okay. Potential for gene-targeted therapy. Swear I thought I had all my typos. My gene target, however you say that. Okay, so my gene-targeted therapy. In other words, what we're hoping in the future we can do is actually take a gene, attach the medication to it, and slip it into our cancer cells, okay? And again, what am I gonna ask you on this? Very little, actually, probably nothing. Definitely nothing. I wouldn't ask something like this, other than to know that the BCR-ABL or any of these genetic abnormalities decrease your chances in these leukemias. Basically, all you need to know from this is that certain genetic abnormalities, depending on which ones are present, are going to decrease your survival rate. They're going to make it more difficult to treat. Okay, see, that was real easy today, right? That was the end of acute. We're not going to try chronic lymphocytics. Yes.
How they screen for genetic predispositions to like breast cancer and such. Can they do that with these and prevent you from developing?
Let's see how can I address that. Yes and no. Yes, we can continually screen people for these things. However, and there might be parents who pay for it, but these genetic abnormalities, basically each one that you screen for is about $700 to $800, and you would have to pretty much screen for them continuously. It's not like you're born with it.
Oh.
These develop at some point. And if you have it in such low amounts, you won't find it. Now, in the children who've had it before, what they will do is, and like James, what they do with him, he has to go in every 6 months, and they draw blood, and he goes once a year for a bone marrow, and they look for that genetic abnormality. In a patient who's had it before, it's worth the money and worth the,
Realize you were born with them, you can always have them.
yeah, that you can't always find them, yeah. It's, I don't know what induces them, I wish I did, but I haven't had time to do a lot more research into it than what I've already done. I learned more from James than I did from anything else. All right, we have a few minutes. Do you want me to leave the room and you'll discuss what we want to do for this test? Do you want to try maybe going over a little bit of what's on here? What do you want to do? Yeah. Oh, yeah. That might help us make a decision. That might be nice, yeah. I'm sorry, guys. I forgot I still have them. I apologize. No, anything's better than a zero.